So, it was very interesting. Recently, I was having a conversation with some clinicians and doctors here. I live in Silicon Valley in California, and it's the early hours of the morning for me. And I was having this interesting discussion with doctors and clinicians of what they said, which was so thoughtful. And I started thinking about that whole area. They spent many years going to medical school, really studying about how to treat patients. But most of their work in medical school was based on the transactional nature of the relationship. If you have a back pain, you go to a doctor. You have a mouth ulcer, you go to see another doctor. You have a pain in your stomach, you go to see a doctor, and there's a diagnosis, and they go away. So the whole nature of the relationship was extremely transactional, and that's how many doctors and clinicians have been trained. And with COVID-19 and the impact of what has happened in the healthcare world today, we are seeing that completely reinvent itself. We're really looking at a different space where previously 90% of interactions were face-to-face. They were in the comfort of a doctor's office where you felt the compassion and the empathy of the doctor. And now it's 90% of that care is remote. So today what we're really going to be talking about is how this year, 2020, has been an extremely unforgiving year for the healthcare world. But yet, on the other hand, I believe it's been a transformative force. So I'll just give you an introduction and set the stage for the next few speakers, as well as the food for thought for us to discuss some of these key important points that are driving this change. So if you go into the next slide, Zainab, if you can move to the next slide. I feel that this COVID-19 pandemic has really been a wake-up call for the industry. In a sense that we've begun to understand that the system does not have a resilient plan in place. Whether we're talking about the workforce, whether we're talking about supplies, whether we're talking about enough beds, ventilators, ICUs, et cetera, et cetera. So it's really showing us the big gap and really a wake-up call for us to build some stress tests into the system. And if we compare ourselves to many parts of the world, some of them have this stress test already set in place and have already put into place some of the machinery to make these changes, while others have not. So what is the impact of this loss of revenues, and how big is the magnitude of that impact? So one of the things we do at Frost & Sullivan is that I have a team of 200 analysts tracking different aspects of healthcare transformation every single day. And we tallied up, just from a manufacturer revenue point of view, what was the quantum of impact. And we came to the conclusion that it was, for 2 months, it was $90 billion of product revenue that will be lost for the year 2020. So that is a huge amount. And so then on, we started doing an analysis to find out what is causing this loss of product revenue that we're going to look at this year. And this does not include hospital revenues. It just includes revenues from pharmaceutical sales, medical device sales, digital health sales, imaging sales, etc. If you look at the loss of revenues coming from hospitals, in the US for the month of May and June, it was $250 billion. In the UAE and KSA region, we're looking at $1.5 billion. In Japan, we're looking at a 10% loss compared to last year for 2 months. So these are some numbers that we are tracking in terms of what is the lost revenues. Now, where is that revenue coming from? I think the first thing that we see is there's a huge delay in product launch. We are looking at $3 billion of products that were expected to be launched this year that did not get launched. Many big trade shows were expected to happen. RSNA in the imaging world, ECR, so many big trade shows did not happen. That is when 50 to 100 product launches take place at these trade shows. So that did not happen. So there's a lot of reasons for the fact that we have lost revenues. Another big area that we're tracking and studying every single day is really the slump in elective procedures. As we know, because of lockdown in many parts of the world, elective procedures did not happen. And I have some average numbers taken from 5 of the largest countries of the world, which I wanted to share with you. We're looking at 100% reduction of procedures for plastic surgery. ENT is 79%, ophthalmology 65%, cardiovascular 53% reduction of procedures. Neurosurgery 47%, general surgery, abdominal 43%, orthopedics 37%, OBGYN 49%. So huge reduction in procedure volume. The third big aspect is the inadequate infrastructure for virtual care. Today, about globally 70 to 80% of primary care consultations are either done online or on the phone or through WhatsApp or through text or some kind of way to be able to carry out this discussion without seeing the patient for the first time, if there are symptoms or not. But do we have the infrastructure to do that? No, we don't. We don't have established telehealth protocols. There are so many things that a patient has to do that they don't even have access to. They don't even know how to take some of these measurements. In many countries of the world, we don't have broadband access. We don't have Wi-Fi in rural areas. Physicians need to be taught about screen-side manner. Nurses need to be taught about screen-side manner. The reimbursement of telehealth, that's a very big question. We're still not there yet. And then, of course, there's security and privacy concerns. So these are very big challenges that the healthcare business is facing. And that is why it makes it even more important for us to have this discussion today on technology. So moving to the next slide, Reenita. I want to just quickly sum up some of the big growth opportunities we see in the different industries. And the reason I bring up growth opportunities is because every single company I talk to, every single hospital I talk to, they ask me this question: how do we grow? How do we generate revenues? How do we make up our numbers for this year? How do we recover and reset ourselves? And that is why I wanted to share with you some of the top growth opportunities we see by different industries. So if you're looking at the hospital industry, obviously the most important area that we see is the whole aspect of building solutions around virtual care. Also the whole aspect of integrating that with smart cities, smart hospitals, and building digital infrastructure within the hospital. I think the second big thing that I talk about is building the hospital to home and the connected infrastructure. This is something that is so critical for the regions that we're talking about today. Building mental health facilities, aged care, geriatric units, standalone labs, which are close to people's homes, which are in the community. Because as we move towards the future, we are looking at a model where the home is going to become the clinic of the future. And we've seen Walmart and big retail giants already make inroads into doing that. And then the third big thing that we're seeing is the need for artificial intelligence, cloud, and robotics as important frameworks that we need to start applying and adapting. Moving to the next slide. So what are some of the growth opportunities in the digital health area? We define digital health as healthcare IT and mobile health, the whole aspect of remote patient monitoring, telehealth, telemedicine. That whole aspect is what we call digital health. So I think one of the big things is, in terms of the region, is that we need better frameworks and policies. We need much more focus on behavioral health and mental health. And we need to create that infrastructure to be able to create the interoperability with different stakeholders in the healthcare ecosystem. The second big thing that I see that the whole digital health industry needs to focus on is the whole aspect of workflow efficiency, process management, better clinical decision support integration, better platforms that work across different units. These are some areas of growth. And then, of course, the whole aspect of privacy and security is very, very important as well. And this is generally across all areas that we are talking about that impacts our lives. Moving to the next slide. So medical imaging is the industry that has been the hardest hit. We're looking at a 40% in the worst case scenario decline of revenues as of last year globally. The areas that medical imaging can really focus on as growth opportunities is the whole aspect of teleradiology and AI imaging. We're seeing much more volumes go up in this new normal system, and we will see some kind of a repressed demand come up, pent-up demand come back by the end of Q4 in these markets. The other big thing is obviously the movement towards value-based products and increased demand for more managed care models rather than traditional unit shipments and buy as you go kind of systems. Moving to the next slide. So what are some of the growth opportunities overall that we are looking at for the healthcare industry on a total level? So I really clubbed it into three main areas: immediate opportunities, short-term opportunities, and medium-term opportunities. And we've also looked at it by size of market. Now, obviously, these numbers are global, but we do have numbers for different countries of the world as well. So immediately we see a huge demand for things like personal protective equipment for imaging fleet solutions, cloud computing, telehealth, critical care. In the short term, which is 1 to 2 years, we're looking at issues like imaging informatics, agile biomanufacturing, and health clinical trial solutions. And then for the medium term, we're looking at a lot of work in terms of using AI for the operating room and creating smart hospitals, AI for imaging, infectious care, and interoperability tools. So one of the things I want to just leave you with is really think about that we have made a lot of progress, a lot of learning. We have in these short 4 months in changing the way we work, in changing the way we interact with our patients and how we treat them. And it's very important to think about how we can take these learnings that we have put into place during wartime and actually build it out and use them more profitably in peacetime. And this is really where our biggest challenge lies, in the challenge for companies today working in this space. So with this, I'm going to pass this on to BII, who will take it on from here. Thank you so much.
Thank you, Reenita. Thanks a lot for your very informative presentation. We'll go ahead with the program, and I'd like to call upon Mr. Yassine Bhija, who's the Director of Enterprise Solutions, Eastern Growth Markets from GE Healthcare, to give a talk on transformation of care delivery with COVID-19.
Thanks, Zainab. Can you hear me well?
Yes, Yassine, we hear you.
Perfect. Thank you very much. Thanks for the feedback. So thank you for the introduction. Indeed, my name is Yassine Bhija. I'm actually heading the solutions business for GE Healthcare here in the region. When I say region, I mean Middle East and Turkey. And today I would like to discuss with you and share our views on how COVID-19 has somehow helped transforming care delivery. And I would really focus especially on digital transformation we see accelerating along different angles, focusing pretty much on the technology aspect, as well as we'll move a little bit more around the benefits we see with such transformation. I'd like to start with this, as a matter of fact. I think we've all seen these memes proliferating and shared widely in social media. They kind of all hint to the fact that COVID-19 has massively changed the digitalization framework, or even the adoption of digitalization in the industry. And we know that digitalization has been around for many years, and we also know that has not necessarily spun off as fast as what we saw recently over the last few months. What is interesting, though, is to look at why. And we believe that actually COVID-19 has accelerated the transformation because it helps in a way aligning the incentives and not only for patients and providers, but also from a payers and the regulator perspective. So for patients, I guess it's quite obvious. We needed healthcare, we needed access to our doctors. However, our cities were locked down and we were unable to visit our providers. On the same time, when the lockdown was lifted, there was a perceived risk of potential infection in hospitals. So finding an alternative way to talk to our doctors was became more urgent. From a provider perspective, the fact that patients are no longer coming, we start seeing hospitals being a little bit underutilized, under capacity, I would say, and risk of potential revenue drop due to delay of elective procedures and reduced patient visits. For payers, it was interesting. From a payer's perspective, technically they were making more money. They became more profitable. And the reason very easily, they collect premiums and they pay out claims. If there are premiums and no claims, then essentially it's profitable for them. However, there was a perceived risk, which I think is an actual risk, of cost spike later because of the deferred care. And therefore, they start acting in a way to reimburse and enable payment for telehealth and digital solutions more than before. And on the regulator perspective, we saw many regulators all over the world becoming much more flexible, relaxing some of the regulations. So just, in the US, for instance, they has this temporarily allowing care to be delivered with through non-completely compliant, HIPAA-compliant devices, relaxing some medical licensing between states, for instance. So we could see actually regulator also being more active in enabling this transformation. Now, the journey has accelerated, as a matter of fact, and you can see from a provider perspective as well as regulation, and here are examples of those where the change has happened and the change has happened fast. So we have examples here in the region from Kings, Habib, Mohaf in Germany, where they also allowed prescription to be able to reimburse prescription, for instance, on digital health applications. So change happened all over the world. When we kind of zoom back and we see the key areas where transformation has focused on, we can see basically three main themes. The first one is clinical excellence. Strong focus on improving the outcomes, reducing care variations. The other element was around operational efficiency, whereby there was focus around optimizing workflows, enhancing efficiencies. And the last one, which I would say is probably the primary one, which we saw as patients, all of us, has gone very high very quickly, is the patient experience, where there was an increase of outreach to the patient and supporting in a way the trend which was going on for some time around consumerization of healthcare. And that had happened through the use of different technologies. We saw telemedicine, we saw wearables more and more, we saw in-home connected virtual assistants, web-based interactive programs. So different tools basically came up to kind of exemplify that. From our perspective, digital health technologies in general should enable a couple of things. First, it should help clinicians prioritizing care based on protocols, on defined protocols, ensure compliance to protocols, aggregate trend information, help in reporting, help on better use of the data and make it actually more an insight that can be leveraged. And these are just examples among many. So what has happened technologically to transform care delivery? What we see first sense was basically the platforms. We saw proliferation of a number of platforms coming up, and these platforms were either around care areas or in departments, focusing on a few things, focusing on enabling remote medical care, improve patient safety, improve diagnostic, as I mentioned, cyber resilience, which become more and more a topic, and ensure trustworthiness of the technology and the access to it. The other element was around smartness, or basically having more and more application and devices be intelligent, helping transforming data into insights to help better decision making. And here I'm not talking only about imaging data. Imaging data is one thing, but you also have aggregation of data from genomics and others that were basically trying to make more sense of than what we used to see before. The last one, and I think Reenita touched also on that, is around AI. So AI become more important, but what we see is basically three main themes essentially that are kind of as focus areas. One is around automating manual tasks, freeing times for clinicians to focus on informed decision making. The other one is actually provide decision support. It's very important, where basically you can help physicians and clinicians to be in the right conditions, have the right insight to be able to make the right decisions for patients. And also, for instance, imaging, where we came from, where I come from, is basically detect patterns in imaging and ensure that what are too subtle or complex to be detected by human eye is easily readable and actually provided to physicians. So now the question that comes is from a benefits perspective. What are the organization benefiting from? And what we see, the benefits of organization come along 4 axes. First one is actually ensuring and enabling rapid response. You can see patient facilities with moment notice just kind of going through the traditional workflows. The second element is actually enhance and improve the effectiveness and the efficiency of care coordination. Care coordination is a massive issue, and actually thanks to these kind of technologies we can improve that. Third element is the quality and handoff between teams and care compliance, and last but not least, actually the productivity of teams through visual rounding across multiple locations and multiple patients. The other benefits I would like to highlight here is the boundaryless collaboration which can be enabled and which is enabled through digital health. So that helps actually connecting primary care, acute hospitals and clinicians with patients, and ensuring that the whole coordination of the pathway is done in a seamless way. And last but not least, is also bridging the care variation. The virtual care path helped by automating protocol, having real-time smart notification, prioritizing patient intervention, and with all sorts of dashboards, reducing care variation, enhancing that there is a higher or better outcome for the patients. Okay? And one element actually I wanted to add here that I think we need to also touch on is essentially the real-timeness, if that even a word in English, of data enabling us to move, enabling predictive and timely interaction. So we're moving away, or more bit by bit, from descriptive engines to predictive engines. Ability to be able to not only gather all the data, make it in a way which is understandable. That's the dashboard, and we saw many dashboards going on for all kind of different players. But it's important also to help make decision better and predict in a timely manner what outcome would be and what the next decision should be. Okay, and that's by aggregating the data, processing it, and actually providing illumination of what to do with it. I would like here just to highlight a couple of digital solutions that we have, at least within GE portfolio, which I thought could be interesting. We have and kind of fall within the same frame. So our platform Edison is our intelligence offering for application and smart devices that we have. And it's interesting because we kind of start from a device perspective, where we're making, through the same platform, our devices smarter, helping us to better use the data, but also enabling through the platform different applications that we develop to generate insight out of the multiple data we get from different sources. And last but not least is creating a platform where people just can come and develop their own application, deploy and advance securely and safely their own application using the wide data which is available and using the platform as such. The other element is actually the telemedicine solution, which we see with Mural, where we try kind of remain agnostic, unlocking innovation, enabling machine learning, trying to digitize the care pathway, and enabling the remote care and actually being more efficient in the way we deliver care. And the other elements is actually our command center. My colleague Modi will explain a little bit later what it means, but with the command center, we're basically aggregating a wide number of data and putting it in a in a sense of a vision control or command center that you kind of see, you will see in airports, and making the data actionable, real-time access to it, and helping us basically with predictive and forecasting, predictive analytics and forecasting through different rooms. And here you have some picture of those. Overall, GE's intelligent solutions and backbone for growth, I think we kind of go through different elements where we believe the transformation is happening. Going from a data content, all type of data that we can have access to provide services through a platform, leveraging the smartness of the devices and being able to make decisions actionable and easy to read. So that what happened before COVID. It got accelerated with COVID. The question that would remain is post-COVID, how do we see that? Do we see that the acceleration would remain at the same pace? Would that slow down? I think it's a real question that probably we can tackle also within the panel later on, but it's an important question that I believe having an overall view of partners ecosystems and all the different players and stakeholders in the industry can help maintain the pace and ensure the transformation that we see with the digital healthcare, and which has been accelerated with COVID. With that, I would pass back to Zainab.
Yes. I think if you have any questions for your...
Yes.
Hi. So if you have any questions for Yassine, I'd appreciate if you can post it on the chat. It would come to me directly and I'll voice it out loud. If you have questions from the panel as well, Yassine is going to be with us on the panel and we can take questions for him even on the panel. And with that, we can go ahead with Molly. She will give us a quick demo on GE Healthcare Command Center.
Thank you, Zainab. Can you hear me?
Yes, I can.
Great. Let me see if I can share my screen. Good afternoon, everybody. My name's Molly Final. And can you all see my screen?
GE Healthcare promoting their product. Shall we digital?
No, not really, Molly. If you do share screen.
Yeah, no.
It shows up now.
Great, thank you, Zainab. So good afternoon, everybody. My name's Molly Final. I'm the Senior Director for the Clinical Command Center team in the region for GE Healthcare Partners. And I wanted to start by just giving you a view of really what a Clinical Command Center can do during a time of crises. So some of you may have seen this in the media, maybe on LinkedIn or in other articles. This is Saudi Arabia's National Health Command Center in Riyadh. And there's three critical components of a command center. So whilst digital transformation is absolutely at the heart of what we do in GE Healthcare, it's also supplemented very strongly by both the actors that you see here, the analytics and the actions that they take. And you may also be aware of this command center. This is Florida Command Center, a very large command center, one of the biggest in the world, that is overseeing the operation of the COVID response across the entire state of Florida. So really by co-locating those actors, we can really solve problems together in real time without having to wait for that communication lag that we see in hospitals.
May I just, sorry Molly to disturb you, may I kindly ask everybody to mute themselves so that we can hear Molly clearly? Thank you very much.
Platform and ultimately they are bringing all to hospital through telehealth.
Thank you, Zainab. So I wanted to show to you today, just in a few minutes, some of the tiles. And when I say tiles, I'm talking about applications. Tiles that are as simple to use as Uber, as easy to see your alerts as Twitter, able to be used on your phone, on your iPad, on your laptop, or in your physical command center. And Reenita referred at the beginning of this session to COVID and 2020 being a transformative force in digital transformation. And for sure, this is what we've seen in GE with our partners and our hospitals. So we've been developing applications that can be deployed remotely, software that can be activated very quickly into hospitals to help them resolve issues as they respond to COVID. The first tile that you're seeing here is a statewide tile called Critical Resources, and you're seeing it, it's dummy data, but you're seeing it for the state of Florida. Critical Resources is aggregating information from a whole range of hospital information systems between every 2 seconds and every 30 seconds, so very real-time information, and providing us with a one-stop shop to see bed occupancy at both a state or a national level, right down to a hospital level. And I'm just going to show you how easy it is for us to drill down right into the hospital and see exactly now which beds are available for patients. Here you can see 6 unoccupied beds on ward CL2C. And this is a tile that's being deployed in region with 76 hospitals in Saudi Arabia and in multiple different states around the world. And the idea is to give bed planners, hospital executives, care managers, the ability to quickly respond and move patients into the correct bed at the right time, whether that's a ventilator bed, an isolation bed, a particular ward for children. And Yassine referred to one of the benefits being rapid response and care coordination. And that's what this tile was really built to do with our partners. And earlier when Reenita spoke about quantum impact, what's the quantum impact of what we're seeing through digital transformation? Tiles like this, we know are making a big difference. We have similar tiles that we took the concept from pre-COVID in both Johns Hopkins and Oregon Health Sciences University in the US, where in both hospitals we saw a huge increase in the number of acute admissions that they were able to make into the hospital by utilizing their beds in the right way at the right time. The second COVID-specific tile that I wanted to share with you today is a tile called Patient Manager. And Patient Manager very quickly gives us a view of patients that we need to see as clinicians and caregivers right now, where we may need the intervention of a service like the command center, instead of calling multiple different stakeholders ourselves. So this is a patient here who has an alert flag for being COVID positive. And if I'm a caregiver on my ward round, I can very quickly go in and see the next step. It looks like transport needs to be requested, and I can and that will go straight through to the mission controller's station in the command center. They can then coordinate quickly with services like transport, pharmacy, radiology, and patient satisfaction to make sure that this patient is getting what they need as soon as they need it and giving more time back to the caregiver at the bedside. And again, this has been created with clinicians from over 20 different hospitals who were finding that their traditional hospital information system is somewhere where they're hunting for information, trying to find variables and factors in the data where they just needed one view at a time of crises. I'll finish just by touching on where we go from here, what happens post-COVID. And Reenita spoke earlier about the issue in revenue loss in procedures and procedural care with the surgical units. And she mentioned, I think, 100% decrease in plastic surgery, a 43% decrease in general surgery. And so one of the things that we've been doing is very quickly creating software where we can start to not just describe problems to clinicians, but prescribe action. And so this is a tile called Surgical Growth. And as well as forecasting the demand over the coming 15 weeks so that we can reschedule patients appropriately, the bottom half of this tile is showing us specific patients that require our intervention right now. It may be that they need their MRI booking that hasn't been done. They haven't had their consent form done, or their case has not been authorized. and ensuring that we can get those slots utilised properly so that patients are not cancelled, their care is not delayed, and our theatres are being properly optimised so that we can recover some of that revenue. So with that, I'll hand it back to Zainab for any questions.
Thanks a lot, Molly. And I'd like to know if anyone has any questions for Molly or the GE Healthcare team that we have present here. If yes, but we also you can post your questions on chat for it to make it easier. If not, then we'll go ahead. Thanks a lot, Molly, for a very informative demo. We'd like to go ahead with our program, and I'd like to introduce Mr. Dave. He's the healthcare leader for EMEA APAC at Avia, and he's going to talk us down through the real world cases in digital healthcare.
Hi, Zainab. Thanks very much for that. Can you see my presentation?
Yes, I can. All of us.
Great, wonderful. Okay, I'll put it into presentation mode. Okay, good afternoon, everybody. My name is Dave O'Shaughnessy. I'm the healthcare practice leader for Avaya in the EMEA and Asia-Pac regions. I'd like to start off this brief session just to give you a kind of a flavor and introduction to who Avaya are, because a lot of people aren't familiar with us, but we are a global communications and collaboration solutions vendor. You can see that we have over 4,000 healthcare customers globally, and some of the customers you can see there are listed. And we're also, I would say that there are also partners as well. So I'd like to particularly point out our partner in this particular event, in this webinar, Converged Generation Solutions, CGC, a very active and proactive and innovative partner of ours in Saudi Arabia and the Kingdom. And also GE Healthcare as well. It was good to see the session from Yassine and Majd earlier on. We're a partner with GE Healthcare on the Mural solution. I'll talk about our virtual care and video solutions a bit further on, but it's good to see them mention Mural. So it was a good session and a good demo from Molly. So we have an extensive healthcare base in the Middle East and Saudi Arabia, and really globally. And what I wanted to do is when I saw the title, how COVID-19 pandemic is reshaping healthcare with technology, and I had the opportunity to share a couple of slides with you. I wanted to share with you some use cases from real hospitals, from real customers of ours across the globe. And I'm lucky in that I get to travel and meet with a lot of customers and hear a lot of these use cases. And I thought it'd be good to share with you some of these use cases. Briefly before, I just wanted to again re-emphasize our value in this industry as a communications and collaboration solutions provider. Those are some of the numbers in terms of how big Avaya is in this industry as a vendor, in terms of 100 million unified communication seats, 2.5 million working from anywhere seats as well. That was obviously a very, very big area where we gave a lot of complimentary licenses away to customers to really help that work from home. And that was also in healthcare as well. And especially contact center as well. I think that's a very, very big area that will change or evolve because of COVID-19 in terms of patient engagement. So one of the areas that I think everybody is familiar with is contact tracing and triage. And that was also a very big challenge for a lot of customers. And how do I quickly contact trace and triage patients who are out there who need interaction? And I think it was mentioned, Reenita mentioned earlier on about the slump in elective surgeries. A lot of hospitals were struggling with the ability to be able to reach out to patients, whether it be on COVID-19 or whether it be simple elective surgeries. And what we did is, in Avaya, we took our original application, which was called Avaya Spaces. So that's a collaboration and conferencing application, cloud-based. And what we did is we amended it and we adapted it so that it could be quickly implemented into healthcare environments, such as what you can see here. So this was a proof of concept that we created for a Saudi customer. And the idea here is that it automated the process of identifying the patients that needed to be spoken to, shared with them a secure one-time connection or URL or link for them to be able to come into a video conference. And this really aligns again with Reenita's point earlier on about inadequate infrastructure for virtual care. What we tried to do here very quickly was create a solution, a kind of a virtual waiting room and virtual consultation solution, which was compliant with any data protection or data sharing issues between the patient and the hospital. So we confirmed HIPAA compliance and also making sure it was legally compliant in different countries. And then the idea was that it was a simple browser-based, app-based solution where a patient could come in, have a quick consultation with the doctor, consultant, specialist, be that again on COVID-19 or any of those elective surgery issues which were important. And that it allowed the patient to have that kind of peace of mind, move on to the next stage of interaction, maybe if it's to the hospital or if it's to the general practitioner. But this is a solution implemented by a number of customers quickly, very, I suppose, adapted to whatever the particular customer was. And I think that's a good example of where virtual care came in. There's a high degree of urgency. It was adapted to what the customer needed, and then we were able to roll it out pretty quickly because, as I said, it was a cloud-based solution. So that's one example from what we've done as a provider to healthcare customers globally. Another one is King Fahd Medical City, so a very important customer for ours in Saudi Arabia in the Kingdom. And this was more in relation to what we call omni-channel patient engagement. So this is a little bit more focused on contact center. And I think everybody on the call and every person participating in this webinar will certainly recognize the necessity or the urgency in terms of evolving how does the patient interact with our hospital or our healthcare organization. A huge, huge area of challenge. And again, an area that perhaps is lacking in terms of infrastructure, because so many times, I think everybody on the call is familiar with, so many times when a patient is interacting with a hospital, often it was one direction or uni-channel, or it was just over voice. It was only inbound into the hospital. There was no other channels of interaction available. But what King Fahd Medical City did together with ourselves is really widen out the kind of interaction and channels available. We call it omni-channel patient engagement. But as you can see here, what they did is they expanded the digital channels that were available for the patient to be able to interact with the hospital. So not only inbound, but also outbound. Not only voice, but email, chat, all based on either web or telephony or also from an app. And I think that's important to stress that last point, the idea of using an app to allow the patient to interact with the hospital at any stage. One of the important features, and one of the discussion points actually later on in this session, will be talking about mental health services and engaging with patients with mental health issues during COVID-19, which of course was wonderful to see it come to the fore in terms of importance and recognition. And the ability for a patient to be able to use services such as a chat service built into an app certainly help to make it easier for a patient. That's really about what the benefit in terms of patient engagement. It should be easy, it should be intuitive, it should be simple. And that's really what a customer like King Fahd Medical City has done with their omni-channel contact center. Start to open up and widen the ability of a patient to interact over multiple different channels, over multiple different ways, automated as well as manual initiated. So I think that's a good example of a customer forward-looking in terms of patient engagement. And actually, I brought up that point on remote patient management again, referring back to Reenita's session at the start. She talked about remote patient management. This is exactly a good example of a hospital implementing a system which allows them to evolve their remote patient management and patient engagement services. Okay. Some of the other interesting innovations implemented by customers. This is one particularly done in a hospital in China, which our local team developed and implemented free of charge recently. So the idea here is with a digitally enabled nurse call system. So in this case, they were using REL and Borg nurse call system. But what they needed was an ability to integrate in with other digital systems. So in this case, their communications platform from Avaya, and they wanted an ability for their nurses or their clinical staff to be quickly contacted and communicated and be able to speak back to the patient. So in this case, a patient who was in their bed, in a secure ICU bed, for example, or in a secure room, needed to be able to contact the nurse. So they would press the button on their nurse call system. That would then go into the Avaya system to then look up a nurse timetable solution, which would identify who is the nurse who's responsible and available at this time. So in effect, integrating in with the nurse timetable, integrating in with the nurse call button, and using those pieces of information to be able to make an immediate decision to be able to contact a responsible nurse. And additionally, if that nurse wasn't available, maybe the nurse might have been already on a call or just not available due to their present status, redistribute that call to the next available person. It's just a simple example of using those digital sources of information to be able to improve the workflow within that hospital. And that's exactly what we're doing here. And I think that's a good example of, again, coming back to the title of this session, using technology to be able to better improve healthcare flow. Another video solution that I really do enjoy sharing with people is one that was implemented in the neonatal ICU in Geneva. So this is the University Hospital in Geneva. And it's a very simple use case example. Here, the hospital wanted to maximize the communication or maximize the interaction between the parent, especially the mother, and a baby who may have been in neonatal ICU. So what we did in this case is we implemented a very simple video solution that automated the process of creating this video connection between the parent and the baby. So in this case, I could probably use my own daughter as an example. So my daughter was born 6 weeks premature and in ICU. And in this case, the baby would be brought into the ICU and placed into a particular incubation box. And a camera would be focused in over that incubation box. The neonatal nurse would update the electronic health record, whatever particular vendor it happens to be, it doesn't matter. And to say that Lily May is in incubation box number 3. And in the background, what we did is we had an automated process, nothing to do. The nurse only required to update the records as usual. But in the background, we created an automated process to send an invitation to the identified contacts, so the mother and father, for example. And that would allow them to download an app to open up a point-to-point video call between that incubation box video and themselves, 24 hours a day, whenever they wanted. It didn't have any noise, or sorry, it didn't have any audio, because if anybody on the call has been in a neonatal ICU, you know it's a lot of noise, a lot of background, a lot of beeps, alarms, and so on. So it's video only, very easily turned on and turned off by the nurse in the ICU in case the nurse needs to intervene with the baby briefly. And as soon as the baby is hopefully removed from the ICU healthy and returns home, the nurse updates the record and the room is automatically deleted. Simple, automated process, but critical in terms of maintaining that visual contact between the parent and especially the mother and the child. And one of the guiding principles that HEG had in terms of implementing a service like this was to help reduce postnatal depression, because the hospital is not a hotel. Parents had to go home, and often the parents could be quite a distance from the hospital, and the mother needs to have that visual contact. And this is just a small, simple way of making that visual contact much, much easier for the parents, for the parents and the child. And they've expanded to use video right across the service in terms of training and education and so on. And we've implemented this also in the Middle East as well with a hospital for adult ICU. Very same use case, very same feature. In that case, integrating in with the Cerner EHR that they have in that case. the final use case that I'd like to share with you is another one that we implemented in the Hushushen Hospital. I think everybody is very familiar with this. I think you'll probably recognize the prefabs. It was the one that was built in 10 days. And again, our exceptional team in Avaya, China, were put to the test, and they implemented this video solution very similar to the one I just shared with you in HUG. The idea being to implement a cloud-based video solution, because in that case, they needed to do it very, very quickly and allow the family members or parents and so on to be able to have point-to-point video calls between themselves and the patients within the hospital. So the patients were provided with Apple iPads, and it was pre-installed with the Avaya app, and the families were notified via email or SMS using our cloud service to download the app, and then given a one-time password in order to be able to facilitate that point-to-point call. And I think everybody on the call is very familiar with the very strenuous, very difficult circumstances that we found ourselves in with COVID-19, where a lot of the times families or members of families who are infected were alone in the hospital because of the extreme issues around COVID-19. So this was, again, Avaya and our local partners, just a small effort to try and alleviate the, I suppose, the isolation and the loneliness that patients had, in this case, offering a very quickly implemented video solution. And again, it comes back, as I said, to Reenita's point earlier on about inadequate infrastructure. We were able to do this very quickly, implementing that video solution for this particular hospital, where it was necessary to react at the speed of light. So that's really, yes, I just wanted to, as I said, give you a couple of examples of where technology really had shaped the healthcare experience for both patients and for healthcare institutions. And as I said, I'm glad to see, you know, on an event like this, very interesting discussions. We're going to have a very interesting panel discussion afterwards that I think we really get into some more details. So I'd like to pass it back. Thanks again for the opportunity.
Great. Thank you very much, Dave, for a very amazing presentation. We have some questions from the floor before we go ahead with the panel, and some of the questions that were asked. One is for you, Reenita. The question that was asked is, these digital transformation solutions require large budgets. Have there been any parallel engagement from banks and financial institutions to help the healthcare sector with this?
Yes, there's in different parts of the world. I think the financial community is realizing the importance of introducing digital in healthcare. And it's purely driven by monetary reasons because of the impact and savings of cost and additional revenues. So there is a lot of efforts to provide funding as well as create public-private partnership projects in countries where you know, access to money.
Great. Thank you. We have another question that was asked is, what is the reason behind being reactive in responding to COVID-19, and could we do any better? I believe this question has been just let out in floor for, and I would ask any of the panelists who would like to answer this question. They can raise their hands or just unmute yourself to answer the question.
Dina, could you repeat the question, please?
The question is, what is the reason behind being reactive in responding to COVID-19, and could we do any better?
Ooh, reactive.
I'm happy answering that. So, of course, COVID-19 was a big disruptor for not only for healthcare, but for everyday life. And as this big disruption happened, we had to take action. So I think we had to be reactive. Otherwise, we would have been in a much worse state. I am glad everybody was reactive. And this is why with technology, with different healthcare advances, we're able to get a grip on it. If you look at the global pandemics many years ago, the response was totally different than the response right now, and the situation was way more worse. So I think it was a good thing that we were reactive. Otherwise, we would have been in a much worse state.
Thank you, Tamara, for taking that question. Appreciate it. And
I think also, if you allow me just to add to what Tamara has just mentioned. So all of organizations continuously run various risk scenarios. So I think our organization, like many others, have mapped out the various scenarios and looked at the potential impact. With COVID, it came with a significant amount of uncertainty. So not to mention the rapid onset and the rapid escalation, but also there was significant uncertainty as to how deep it would be and how long it would last. And I believe this is where most of the challenge was. But the initial reaction and the initial response, most large organizations are usually prepared for various risk scenarios, which include cash flow management, for example, and incidents of disrupted business and revenue streams for extended periods.
Thanks a lot, Dr. Majd, for your inputs. May I kindly request everyone? Yeah.
Just from a clinician's perspective, I feel that I have a slightly cynical view of how we reacted, and I completely agree that it was reactive and not proactive. I think the writing was on the wall, say that a lot of the scientists, the virologists had said for a number of years, there is going to be a pandemic coming soon. It's only a matter of time. I think we were blind to that occurrence. So just because we were blind to the occurrence and calling it a black swan event, I completely disagree. I think it was, as a society, as a larger than an organization, we should have seen the writing on the wall and believed them rather than them being labeled as Cassandras. I think we did well, but we were still reactive. I also feel as adopters in the medical field, in the healthcare field, we are late adopters of technology, of processing. We are risk averse as providers and as healthcare professionals. We like the technology to have weathered a few storms, only then to adopt. This has probably shown us that sitting on the fence is not good enough. We need to now manage whatever's coming next. I think what it has done to us as a society, fortunately, is it's opened our horizons a bit more. To say, what you know is what you know, but what you don't know, you don't know. Sorry, they can't put it in any better words.
Thank you, Dr. Rahul, for your inputs. And we'll now leave the floor back again to Reenita to take over and to open the panel discussion.
Wonderful, Zanab. Thank you so much. So thank you for all the speakers so far. Yassine from GE, I enjoyed some of the points that you brought up. And Molly, your presentation was just amazing, simply because I think 6 or 7 years ago, I had the honor of actually providing and nominating GE for their command center and John Hopkins for an award in terms of disruption. So I'm very, very familiar with the work that your organization has done in terms of disrupting what is happening with the operating room and hospital in general. And I think, Dave, it's amazing to see some of the use cases that you presented to us and some of the technologies that are showing the compassionate care is possible using technology as well, and changing the paradigm and the equilibrium of what is technology versus not. So today we have a very, very interesting panel discussion that we're going to have. We have 7 or 8 movers and shakers from different parts of the industry, which makes it more interesting. We have people from medical device companies, from technology companies. We have stakeholders from the provider space, the hospital space, the payer space. So we have various viewpoints that we're going to funnel in and expose and bring up in terms of how technology is useful or not. and how it's fared so far and where the future of technology is going, and are we looking at a new world of healthcare which is going to resemble some of this Zoom world that we have entered over the last 3-4 months. So with that, I'm going to have each of the panelists do a quick introduction about themselves, not more than maybe 30-40 seconds, as we have a number of people to go through. So I'd like to start with Maz, if you can go ahead and introduce yourself.
Thank you, Reenita, and I'd like to welcome all the participants and panelists. My name is Majd. I'm the Chief Operating Officer at UEMedical. Our organization owns about 75 hospitals and clinics, which are distributed between UAE and Saudi Arabia. We differentiate ourselves on the basis of specialization and have a number of centers of excellence. Most notably are women and children's health, assisted reproduction and genetics, diabetes, and chronic disease management. More recently, we've been focusing on integrated clinical research and education in collaboration with a lot of the leading academic institutions in UAE and healthcare institutions globally. A lot of this research is focused not only on patient care, but also on innovation and digital health. Thank you for giving me more than 30 seconds.
No problems. Dr. Shafi, are you there?
I think he hasn't joined yet, so if we can.
Okay, let's go to Tamara.
Hi, my name is Tamara. I'm a primary care physician by practice, and I'm currently the medical director of clinical informatics at Johns Hopkins Aramco Healthcare. Johns Hopkins Aramco Healthcare is actually one of the largest oil companies, as well as the leaders in healthcare in the U.S., Johns Hopkins Medicine and Saudi Aramco. It's my pleasure to be with you at this panel today. I have 25 years of experience in informatics, and I'm glad to be here today. Thank you.
Thank you, Tamara. Dr. Bassam, I just see that you've joined us. Can you just quickly give an introduction? We're just at the point of introducing ourselves. Thank you so much and welcome to our panel.
Oh, hi, my name is Bassam Mahboub. I'm a consultant of pulmonary medicine and allergy immunology. I used to head the Dubai Healthcare Authority Innovation Team for 2 years.
Great, thank you. Alaa from Wolters, Kluwer, do you want to go ahead?
Yeah, thank you so much, Reenita. So my name is Alaa Darwish. My education background, I'm a pharmacist, graduate pharmacist. I've been really passionate about transforming healthcare and enhancing healthcare provision, specifically in this part of the world for the last 20 years. Currently, I'm privileged to be working as country manager for Wolters Kluwer Clinical Effectiveness, which is a global leading technology provider providing clinical decision support solutions, mainly used at the point of care. And I think we had an impact during the COVID pandemic that we'll be happy to share, definitely. Thank you.
Wonderful. I'm going to skip Yassine because we just heard from him, and I'm going to go to Rahul. Dr. Rahul.
Hi, everyone. Thanks for coming this afternoon. I'm Dr. Rahul. I'm a consultant family physician. I still practice at Mediclinic. I'm a physician informatics lead. My usual tagline is that technology doesn't excite me, but what technology brings to the consulting room excites me. So what excites me is the value that technology adds to the discourse between the doctor and the patient. And that's what's important. Everything else is just a stethoscope on your desk. Thanks.
Thank you. Robert, are you there?
Yeah, I'm here. This is Robert Denson. I'm SVP of BLAFI, which is the Health Information Exchange for Abu Dhabi. Been out here for about 18 months, so learning quite a bit about the region. Previous to that, I was the Chief Information Officer of Korea, which was a state-wide health information exchange for the state of Colorado in the United States. You know, and I'm proud to be on this panel. So thank you for the invite. You know, I've worked with many of the folks on this call and organizations I've worked for in the past as well. So it's a good panel. Thank you.
Thank you, Robert. So I'm going to go straight into my first question, which I'm hoping that everyone can contribute, because since everyone is coming from different sectors of the healthcare industry, I would like to have each of you share your experiences of what are the top challenges your organization faced as a result of COVID-19. And also through that process, maybe if you can talk about what are some of the technology solutions that your organization or you personally were involved in using that helped with reducing some aspect of the pandemic, whether it's a solution regarding AI or a solution with efficiency or a digital contact center or virtual visit, whatever that might be. So let's start with Maz, if you can go ahead.
Excellent. Thank you very much, Reenita. I think in the presentations, we've seen a lot of excellent use cases for what digital technologies have contributed. And I believe we can all agree that digital technology was certainly the driving force and at the forefront of the fight against the pandemic. What we've realized over the past few months is that people are more utilizing and adopting existing technologies rather than the sudden emergence of new technologies. The only exception to that rule is something that Dave mentioned, which is established platforms being repurposed in whole or in part to be able to serve a certain function during this period. So what's most important to focus on is that given the sudden rise of the pandemic and the reactive mode, there was definitely no time to develop new technologies. But the surge that happened in existing technologies was extremely phenomenal. Look at Zoom, for instance. Zoom is almost a decade old. In the 3 months of the pandemic, Zoom saw a 3,000% increase in the total number of new users on the platform. Telehealth is the same. So we've seen organizations report up to 6,000% increase in the use of telehealth to be able to deal with patients' needs. For us as an organization, telehealth was something in the pipeline, but did not come into effect until we were obliged to seek it out as an opportunity. Our main concern was to ensure access to and continuity of care for our patients while keeping them safe at home. This was especially important for a very large patient cohort, especially the elderly patients with chronic diseases and children. We quickly launched teleconsultations using a white label solution. The organization was very agile with an excellent IT infrastructure, very young and dynamic leadership, and clinicians who were able to onboard and adopt and understand the technology relatively quickly. This helped us provide the needed care for thousands of patients. We were able to check up on them through video consultations. We were also able to provide refills for their chronic medications using our very own online medication delivery solution. And that was the first. This is something that we had been working on for a few months and took the opportunity to launch it amidst the pandemic and offer this service not only to our patients, but to patients across Abu Dhabi and the entire Emirate. What's more important than teleconsultations, our occupational therapists and speech therapists were actually able to perform teletherapy for a group of very vulnerable individuals, children with developmental disorders, who had been undergoing treatment for years. And the impact of not receiving care for a few months would significantly result in a regression of their conditions. So not only were we able to consult and fill prescriptions, but we were also able to deliver various methods of therapy through video consultations and teleconsultations. From a business perspective, it was equally important also. As an organization, we needed to be resilient. We needed to be able to respond to the significant decline in patients and revenues in some areas. we relied extensively on business process automation and real-time dashboards to be able to monitor capacity utilization at various units for various specialities. This allowed us to continue to deliver services which were very much needed. And some of the figures that you mentioned, Reenita, are alarming. And we are aware of some healthcare providers losing 90% of their volumes and revenues during COVID. So having such a tool to monitor utilization was empirical to allow us to continue to expand services where there was demand, but also to consolidate and pull back services where we had a significant decline in demand, like dental services or elective procedures, for instance. We also managed business process automation to look at supply chain, specifically when it came to stocks of PPEs, which I assume many organizations had, but we had the privilege of having real-time dashboards rather than going to manual systems. So basically a bundle of different digital solutions and innovations aimed at patient care as well as business performance.
Thank you so much, Marsh. That's a wonderful array of technologies that have been used to look at the pandemic. I see that Dr. Shafi Ahmed has just joined. Dr. Ahmed, if you can introduce yourself and then take on the first question, which is primarily what are the biggest challenges the organization or yourself have faced as a result of pandemic, and how do you see technology solving some of that?
Yeah, thanks. And thanks for joining a little bit late. I'm Shafi Ahmed. I'm a surgeon, cancer specialist based in London. Also with the Abu Dhabi government in terms of supporting and advise them on their digital health transformation journey. I'm also a 5G ambassador for Vodafone and the implementation of connected health across the UK. So look, I think the challenges from a clinical perspective have been numerous. One is around how do you restructure the services. So that means how do you cancel elective operations, what's pertinent, what's reasonable, how do you manage cancer work across the trust, across the UK, allowing people to get treatment as appropriate, and then rationalise the treatment that's at high risk. We've struggled with that, I guess, over the course of the last 4 months, and now we have a backlog of almost 200,000 or 300,000 elective operations that we struggle to work with going forward about how you redistribute the workforce appropriately. The second one is around workforce. It's around how to use the workforce more effectively during a pandemic, knowing that they'll be on working much more hours at the front line with the emotional stress that's required and the mental health well-being being compromised over such a period of time. How you manage that, the next pandemic coming along or the second wave, for example, how you can manage the workforce accordingly. And the last thing is around training and teaching. You know, if you look at in the UK, for example, we've stopped training and teaching for 6 months. Everyone's training situation has been stopped until we start getting to a place where we can train. Surgery has been hugely hit with no actual training for our trainees. Therefore, they will delay their 5-6 year program and delay their exit to become a specialist. So the question is, how do we do remote training and teaching, both at medical school level and at postgrad level? So we're now working on ways of remote learning, remote teaching. We've moved, of course, to that perspective. The last point to take on the last question that we were discussing earlier around telemedicine, that's been a key issue, of course. We moved to virtual clinics. In fact, yesterday morning, I was doing a virtual clinic on my laptop with the electronic health record on my own laptop at home, with a virtual smart card, and also an e-consent, consenting people operations remotely using software. So now we're approaching this way in a different fashion. As we unlock, as we start doing more face-to-face, what does that new world look like? And I suspect we won't be going back to normal again. This is a new set, a new normal, the reset, if you like. And I see it as an opportunity, actually. Although we see the challenges, I think it's a huge opportunity for innovation to be driven hard, to be translated into clinical practice. The door is slightly ajar now, and there's huge barriers of adoption before with regulatory problems, etc. Now we're seeing a much more open door policy, people willing to change. And I've seen a huge shift in the mindsets of people. Before we had the early inventors, the adopters, and the people lag behind, which is the vast majority, and now that's moved further along the line where more people are now being innovative. It's actually very helpful for change. The last point is about patients. We've often underestimated their digital savviness, or the fact they want to change, have access to healthcare in a different way. We've been very hierarchical in the way we've approached medicine, that we know best as doctors, this is what's going to happen, this is how we can drive ambition. And that's been changed now. We're now more patient-centric. Patients have got a voice and a demand. The healthcare needs to be more immediate, more remote, and accessible. And suddenly the whole thing is shifted. So although there's been challenges, I also see there's huge opportunities now to drive and reimagine healthcare for all of us across all parts of the world. And that's what I concentrate on going forward, how we make this stick, all these areas that we've improved upon, and use as a springboard to accelerate change in the future. Those are kind of my initial thoughts around that question you asked me. Thanks, Reenita.
Thank you, Dr. Shafi. I think you bring up some really, really interesting points. Let's move now to Tamara. You can go ahead.
So I think it really depends on major challenge on which phase we're talking about. So initially, I would say first phase, with the rapid onset, there was a lot of chaos. People didn't know what they were doing. We had a lot of anxiety and emotional instability of people because everybody was in a panic mode. As we move forward with the pandemic, and we'll talk about that middle period, which was like flattening the curve period, time in which we asked everybody to stay at home. At that point, you had people who had medical conditions who were actually dying of getting heart attacks at home more than getting COVID and COVID-related illnesses. So that point of that period carried that uncertainty. And I think a lot of us are moving in the third phase right now, which also has its challenges, is going back to the new normal, opening to the public, trying to reach out and get all those anxious people who are sitting at home who do not want to come into the hospital, who have delayed medical care, getting them back on board. So each of these areas had its challenges, from getting the PPEs and getting the equipment and the dashboards, and each one had different solutions. So of course, each phase we had different solutions to help get over that part. The majority, I think it's really, really important that we had a very strong infrastructure, meaning a lot of these technologies we had implemented in some way before, because there's no way you're going to implement a whole telemedicine program which is secure, which provides everything you need in such a short duration. So some of the technologies we've implemented was telemedicine video visits. Luckily, we have a very good electronic health system that enabled us to create those video visits along with all the workflows that need to go along with them. We also created a COVID-19 home monitoring program in which patients are actually at home and they are being monitored remotely through us, and we're following up on them while they're sitting at home, whether they're contacts or actual low-risk COVID patients. We also had our telephone visits because in some areas we couldn't do the video visits. So we had some services, especially when we're launching the video visits to the different services and getting them up and about. We started with telephone visits. We also had a COVID care line because we often forget about the patients and the anxiety of the patients. So we have both an emotional support line for both the caregivers as well as the patients, as well as a COVID care line to answer their queries and questions. We also had a nurse care line. So the patient would kind of know, or they would walk them through protocol triage, evidence-based ones. So the patients would know what they should do next or where they should go based on their symptomology. As well as we had something similar to what Dave showed us with the virtual visits, because of course, all these patients in the hospital, nobody can visit them. So we had virtual visits enabled with their families. So anytime, anywhere visits. We had medications, which are prescriptions with home delivery. So everything's done online and medication gets delivered to the patients from their home or picked up from a central, like a window. And of course, it's very important. We had also best practice advisories that kind of stratified the risk of the patient. So we know which ones are the high risk, so we can tailor their treatment based on that. And with people, especially that phase when everybody was at home, when we were flattening the curve, we had a domestic abuse support line, because at that moment, people are, sometimes they're not used to sitting at home together. So I think domestic abuse was one of the things that we were really worried about. So we also launched that. I think this opened, I think emotional and well-being is something we as caregivers really tend to like give a backseat to. But with COVID, I think it kind of opened up our eyes to like pay more attention to emotional state and more of wellness. I think COVID opened up a lot of our eyes to different things that we took for granted in our day-to-day lives. Thank you.
Wonderful, Tamara. I really liked your touch on the mental health issue. I think COVID has brought to center stage the whole aspect in healthcare that we put always behind the covers on emotional health and mental health, and how much that really impacts the clinical and the biological outcome of any drugs that someone is having. So that's really a lot of progress that we're making in terms of treating a patient on a holistic level. Let's move on quickly. Dr. Bassam, do you want to contribute anything to what you're seeing on the floor actually?
Yeah, so I will say a quick comment because I was just asked to see a patient. So I'll just try to make it quick here. So we're going to add a lot about what COVID made us. It's almost like you took the whole scene of technology into a fast forward. So 80% of our patients were telemedicine. Few of them were televideo, not as opposed to the telephonic, which is similar to what everybody said. But let me just take it to another angle, which is the research part. We have been very much active in terms of having a COVID research team. The country had probably around 60,000 patients up until yesterday, but we were able to meet with all universities on the Zoom and Microsoft Office and all that kind of things. But the thing is, we were able to get work done in terms of research. Not only this, we are trying the first implementation of the digital clinical trials, which is going to be so much fast forwarded, which is how you recruit and you put the whole platform into a digital platform that will make it easy, cheaper, and most effective for both funders and users. So these are the main things that I'd like to say. And of course, at least 3 or 4 projects that we are doing is involved with the using of the artificial intelligence. So we're using the AI in clinical predictive analytics. We are using AI in radiological predictive analytics and comparing it with the CT. And we also using AI to read transcriptomics, which is the genomics from host and virus. So it's going to be an exciting area where you get technology to be there all the time. That's all I have to say. I'll see a patient and then I'll come and join you later. Thank you very much.
Thank you so much. Thank you so much. Really appreciate it. Your comment on virtual clinical trials is so true, because we are kind of predicting that 30% of all trials in the future will become virtual, and that leads to a huge development of the clinical trials IT solutions market. And we're predicting some numbers of around 560 million for the rest of the year for the clinical IT market for supporting trials. So that's wonderful. Thank you. Let's move on. Our next contributor will be Alaa from Wolters Kluwer. Do you want to go ahead, Alaa?
Yep. Thank you so much, Reenita. So thanks for the question. And absolutely, like humanity, Wolters Kluwer clinic effectiveness, we were actually challenged by the COVID-19 pandemic. And part of that because our customers were challenged, healthcare professionals were challenged. So we saw healthcare professionals caring about patients and mainly trying to reduce patient duration of stay and reducing mortality of patients, enhancing patient outcomes in a situation where evidence were very fluid, very fast changing. But that was the area where we stepped up, because that's what we've been doing for the last decades, developing clinical data and putting the evidence readily at the clinician side at the point of care. So Wolters Kluwer have actually curated COVID-19 data or related data, have researched the evidence that was evolving using around 7,000 of our experts globally and our professors of medicine that we contribute with to review all publications around COVID-19. So we've curated the data that comes into 3 of our solutions, and these solutions are up to date, EMI as well as Lexicom, so covering clinical evidence, referential drug database, as well as patient engagement. So that curation of data have led that we have had a COVID-19 topic. And actually, as our social responsibility in Wolters Kluwer, we've made an open access globally to all health professionals to access all the curated data free of charge on COVID-19. Moreover, as well, this data was reviewed on daily basis. At points in time, we had 70 updates to the data and the clinical evidence being provided. All the content provided was graded according to our grade recommendation system. And then that have provided the clinicians with the artillery that they needed to have the evidence to manage the evolving evidence to manage at the point of care. This also came with the trust that the physicians had initially and the clinicians, healthcare professionals, as well as patients had in our solutions. We have more than 1.9 million users daily using UpToDate and Lexicom and other solutions that we have. So that came, we built on that trust, and we continue to provide the community where we serve best with our best efforts during the COVID-19 time. So, I mean, many more things to say, but just to let you know as well, we have developed a COVID-19 triage pathway. That means for clinicians, we've incorporated all this curated data, and then we put it on a pathway, and around 2,000 organizations in around 135 countries have used this pathway to manage their COVID-19 patients. So many more to say, but to give you an example, that what resulted in around 10.4 million views of our COVID-19 and reviews of our COVID-19 data that was published and have helped the clinicians make these decisions globally.
Thank you so much. Let's move on to Yassine from GE. Please go ahead.
Yes, thank you. Actually, I would like to take a different angle to the challenges, but and also would give me the opportunity to pay tribute to some of my colleagues that have shown a resilience that goes beyond the world. So I have 3 examples that I would like to share here. The first one is with respect to our remote capability to service our equipment. I mean, our equipment has been playing a crucial role in the pandemic, and it's never been urgent to keep these machines up and running. And we've seen actually our field engineers who essentially their mission is basically make sure that these machines are up to date, go and actually within curfew times and lockdowns and whatnot to deliver and make sure that the machines are maintained and operational. However, what was quite stunning to us that the pandemic really helped us to kind of accelerate is really boost our online capabilities by having dedicated online engineers working from home during the lockdowns on their laptop, being able to diagnose and repair machines via secure internet connections. And we found out that actually more than 30% of the time we could basically help hospitals and clinics get their machines back online immediately. While historically, customers would ask us to come and visit, and that would basically take more time. So that was an example. And the interesting piece here is not that we didn't have the technology before. The technology was there, but our customers and hospital became more accepting to have such services delivered remotely. As a matter of fact, they've been asking for it, and there was no other option. And I think that is part of the acceleration that that happened in a way thanks to COVID, and there is no way back. So we will just continue that way, and we make sure that more and more machine and service that we can deliver remotely help in the efficiency of our clients. The other example I would like to bring in is what Molly presented earlier around the COVID-19 tile. So the command center, as it was presented, we received a lot of requests from our customers to develop something that can help them manage the pandemic and manage the allocation of beds and patients. And it was actually stunning to see, where typically, and I hope Molly would not be mad at me, but typically those developments of application take weeks and weeks because they're complex. So suddenly developing those tiles has been done over a couple of weeks. We try to make it standard, easy, and we managed to scale it in such a fast manner because the people were so dedicated about the mission and the ability to help. And we managed to basically scale it and support many customers across the globe, which ultimately otherwise would have taken us ages. And the last step, which is not really around, the last example, not really around the technology per se, but rather, as many of you would know around the processes. So many of you would know that basically our ventilators have become or ventilators in general have become so scarce in the market. And those was very impressive to see essentially how our teams have been able to, and actually how our customers also been responsive, providing us all the equipment, repairing our remote repair centers we have in Turkey and Saudi, and turning around very quickly to make them available to our customers. And in the back of our head is actually every ventilator that we make back available and functional will basically help save lives. And these are basically the three examples which really kind of to me stood out, and I thought of sharing.
Thank you. I think that was a wonderful plethora of different areas that your organization and yourself has made impact. Dr. Rahul, let's move on.
Hi, I mean, from a clinicians and from a healthcare provider perspective, to us, at least in Abu Dhabi region, the healthcare exchange, information exchange was of immense use because we were suddenly jet set into a telemedicine world. So I don't have access to the traditional way. A patient brings me their results from this hospital or the other. The care is quite fragmented here in the region, as we all know. And I don't get an oversight of their results or everything unless the patient presents me with a stash of papers. So now we have a health information exchange where I can, on a click of a few buttons, understand the patient's latest results, including COVID. We have the patient's recently prescribed meds, diagnoses, even radiology summaries. So that was a game changer, including the adoption from the clinicians and from the patients to the program. The other aspects, as others mentioned as well, was teleconsults. We had a lot of skeptics in the group. Practicing clinicians, Dr. Shafi and all would probably agree. Clinicians always usually are not the easiest people to manage. But because of the COVID crisis, we were put in a situation where that was a tool to use to treat your patient. And that's a language that clinicians understand. We had delivery of meds, home delivery of meds, which happened as well, which was a huge, which had a huge impact or positive impact on the patients. Just a spin that I had was, again, from a clinician's perspective, speaking for the clan, I can't be but a bit cynical of how many of these newly acquired technologies, capabilities will stick onto us, or is it just a blip on the road and we forget about it down the line? It would be interesting to see. Especially, I'm a follower of Reenita, you can close your ears, of Gartner's hype cycle. It's quite useful, and I'm waiting for their latest release to see what their hype cycle shows in terms of technology. Just a year or a couple of years ago, what impact did it have on their hype cycle? Cheers.
Good point. Good point. Let's move on to Robert. Are you there?
Yes, thank you. You know, Malafi was uniquely positioned at the start of this pandemic, and I don't say that lightly. You know, there was some forethought and obviously some dollars put at building the platform. And as Dr. Rahul said, we were able to provide information in a real-time fashion to the providers. But beyond that too, I mean, we expanded rapidly, like many of the technology companies that have already talked before me. We were able to listen to the needs of the regulator in order to provide them insights, again, in a real-time fashion of what was happening on the ground from a testing standpoint, turnaround times, challenges that we're seeing, which, we'll get to eventually on this panel, and able to react quickly to those, to give them insights that I'm sure helped in their decision-making as Abu Dhabi moved forward in response to the pandemic. Likewise, too, we listened to the regulator and our participants, as workflows changed within the hospital setting. That was something I don't know if ever, me as a technologist, I don't know if I understand that well enough. So I need the folks like Dr. Rahul and Majd and others, to come to us and say, here's a challenge. How can you solve it for us? And we're able to put together, an application that can view COVID tests in seconds, right? Rather than what it may take previously to find that information on Robert Denson should he present himself. And then not only to the physicians, but to their supporting staff as well, which is key. I think that was helpful to the community. So we continue to look at the different challenges, because I don't think this is going to go away anytime soon. So we're listening to different feedback from those physicians, clinicians, supporting staff, and the regulator to continually adapt. And I think, it certainly has put our teams in a different thought process as we move forward. One of the presenters earlier said, digital transformation is a jar. From my perspective, it's wide open, and we need to continue to expand on it.
True. So let's focus on specifically, we heard a lot about telehealth today. So let's focus a little bit on that. We know that the industry is facing almost 300% exponential growth as a result of COVID-19. And my question really is that once this pandemic dies down, and Rahul alluded to this as well, what should we be thinking about to ensure that some of this virtual care continues? And what we need to do in terms of standard of care, and it's not just some Wild West model that we employ temporarily. So with that question in mind, let's focus specifically on the patient. Let's think about, what kind of patient expectations should we be thinking about? What tools do we need to provide the patient to make it a sustainable model, whether it's navigation tools, whether it's patient engagement tools, whether it's patients being able to report outcomes and take more charge of their health and share data across platforms. So let's start with that first question. I'd like to address this question to Rahul first, and then we'll have a few more others join in depending on time.
Thanks, Reenita. Yeah, I'm completely agree with you here as well. Again, I think usually the process flow for any medical workflow or new healthcare workflow is governance and tried and tested, and the workflow then follows. I think COVID as an enabler, if you like, changed that a bit, and the pyramid was toppled on its head. So the workflows happened, and the governance is now playing a bit of catch up in terms of what's best practice. I think what we see as governance currently is still ad hoc. What will happen sooner rather than later is governance structures, which with each regulator, making sure that the delivery of the digital delivery of care, which is the new methods, subscribe to a structure and avoiding a Wild West attitude to it. Now, again, the change management aspect kicks in, because you have a better chance of clinicians and the allied healthcare providers to stick to structures and governance. If you do it as a first cut, we are now going to have to do an exercise of retro-fixing it and asking people to say, you know what you did there was fine at that time, but from now on, please do that. That's going to be a big challenge, I feel. In terms of outcomes, we need to see how did we do well probably another quarter or so, we would get to say, were there any variances? Were there any adverse incidents? Were they related to the transformation per se, or were they commensurate with what happened last year, same time? I think these are all things that are still work in progress. We would only know once there are metrics and KPIs set to measure them against. Cheers.
Thank you. Alaa, do you want to answer? Or?
Yeah. Yeah. So yeah, definitely. So the point here is that patients are the most impacted in a healthcare system. However, they are the least participating in the different key decisions. And I think bringing up that participation level and having more patient engagement definitely shows a reflection on positive outcomes in healthcare. Thinking of that, we might think of COVID that you know, globally we needed to increase patient understanding of how does the virus can be transmitted from one person to another and so on. So that awareness is very easy. So now technology as well enables more of that patient engagement, and in different setups, utilizing technology with the greatest evidence that we have, and having a mix that integrate the voice recognition technology into electronic medical records by bringing in the natural language programming that we have. So then you can interact with the patient, engage with the patient, have the patient giving their input either through a chatbot or through the voice or over the desktop, but then this data is integrated into the electronic medical record. Coming into that, you add artificial intelligence into the mix, which allows then a combination that allows responses that really tackles specifically to that patient case, while the patient is still kept remotely but engaged in out of the health system. So there are different examples definitely to do that, but this has been utilized extensively through our ME solution, which brings the natural language programming, artificial intelligence, as well as voice engagement of the patients, as well as chatbots that we use to integrate all of that and reach a decision that helps the patient be more engaged.
Does anyone else from the panel want to address something that has not?
Yes, I think I'd like to focus a little bit on the patients and maybe the ecosystem. Consumers in general have been drawn to digital technologies over the past few years. So you see a lot of people preferring to do online banking, online booking. Wherever digital technology is available, they're happy to embrace it. Healthcare consumers are no different. And this is where perhaps I disagree with some of the panelists. What we've seen over the past 2 years is healthcare consumers embracing digital technology. They want to be able to access care easily, conveniently, comfortably. They're also, I agree with the gentleman from UK as well, a lot more empowered. They want to have access to their medical records and various parts of their health charts at their fingertips. At the same time, consumers or individuals in general have incredible access to monitors or wearable devices and various apps. And we can see many people tracking things like physical activity and nutrition. Some people are even tracking sleep patterns. As far as 2 to 3 years ago, we even have patients at our diabetes center, elderly patients as well, who are monitoring blood glucose levels using sensors and smartphones. And I'm talking as far back as 3 years ago. So you can imagine the abundance of data which is available from all of these different monitors, sensors, and devices. I believe the challenge, so now we have an empowered healthcare consumer. We have an engaged healthcare consumer. I agree with everyone that definitely we need to see more engagement, but I believe the cycle has begun. One of the key challenges, and I think Yassine mentioned it in a lovely slide in his presentation, is aggregation of all of these data points. I believe we are at the point now where we have so much data that we need someone to be able to aggregate this data and utilize this data to make better informed decisions that can significantly enhance the overall wellness and health. So not only health, but also wellness and well-being of individuals. And I'm happy to see that there are various data aggregators which will take this information and put it out in a more easy to understand and easy to action format. When you look at why digital health is not taking off as much as it should, I believe payers still generally are skeptical of the impact and the value of digital health. So although they were keen to embrace teleconsultations, part of it was mandatory. In Abu Dhabi, the Department of Health mandated all insurers to pay for teleconsultations. They even went a step ahead and determined the reimbursement rate to avoid unnecessary negotiation between payer and provider. So obviously payers are very skeptical about the benefit and value of digital health. And I agree with the team members that we need to produce more data on the quality outcomes through the proper and effective utilization of digital health solutions compared to normal traditional practices. So definitely by investing more in demonstrating this value, and value can be gained through multiple ways. Value can improve access to care, improve the overall patient experience, improve the quality outcomes, and through efficiencies, reduce cost. So I believe the onus is on us to demonstrate the value of these digital transformation solutions in order to allow patients, regulators, and payers to embrace these technologies.
Thank you so much.
I'd like to actually add on Majd's point there, which I thought was very interesting about there's certainly a demand from the patients for this kind of remote health, telehealth services, and there's certainly a demand from the healthcare institutions and organizations. As a vendor, one of our biggest challenges in talking to customers about such solutions, about remote patient management, telehealth, etc., from my experience, certainly across the EMEA and Asia-Pac region, maybe less so in the US because it's one regulatory area and they have HIPAA compliance. But one big area that a lot of our customers have been really concerned with is regulation, and different regulations in different countries, evolving regulations, and in many situations, regulations haven't modernized in line with the provision of telehealth and remote services. That certainly seems to be a concern. I don't think there's a concern that the technology isn't there. That is certainly the case. I think everybody can see here that vendors and so on are providing excellent technology. And I don't think the adoption from patients is not there. I think you said yourself that patients are ready to do this. But I think Majd's point there as well about payers, they're also reluctant, maybe not reluctant, but I think he used the word skeptic or skepticism about adoption of these services. That in line with potential impacts on regulation seems to be a very big topic. You could talk for hours on that.
Reenita, can I just add a very quickly about the patient perspective? It's the fact that, look, I think, we all talk about being patient-focused, patient-centric, which is the right conversation to have. We're seeing more engagement, but ultimately we don't engage them enough. If you look at this, I've been on countless webinars, as I'm sure you all have over the last 3 or 4 months. We very rarely hear the patient voice on these webinars. Even today, we've got tech partners, we've got clinicians, but no patients talk about their requirements and their interests. So that's the first fundamental issue about having the support stakeholder in these conversations. The other thing around is that we need to make sure that we look after the patient population as a whole. There's those that are going to be very supportive, move with innovation. Those are vulnerable. How do we create seamless society, seamless healthcare system that supports all the people in that system? The other thing about technology, I run a number of startups, work with innovation partners. And if you look at any old technology company and startups, they're always desperate to have a CEO, a CMO, whatever. they very rarely have a CPO, a chief patient officer, to drive the ambition, to say actually what we're doing is relevant to patients. We're not seeing that kind of work that's in conjunction with our patients as partners on that journey to make healthcare more accessible, more affordable, and ultimately more equitable. So I like to see more of a relationship building exercise to allow the patients to have demand and voice to ensure they are not trapped, they are more involved in our decision making.
Yeah, Shafi.
Okay, I'm going to take a pause now, if you don't mind. We have 10 minutes left, and we have a lot of questions from the audience, which I want to get to for the next 10 minutes. So please go ahead and jump in if you want to answer the question. The first question that we have is, have we impacted negatively on providers and client safety when we focused on the cost? Did it result on more infected people because of being so strict with the number of supplied PPE? And how much has that cost us in terms of increase and rate of infection? Does anyone want to take that question?
Sorry, I don't think the question was very clear. So the question is that we have increased cost because of the PPE. I didn't get the.
No, I think the question was that did we focus a lot on cost and not put in enough into the system that we needed to put in, which may have increased the numbers? Were we more stringent on the cost aspect of it and not on the quality or whatever that we needed to do?
I can try to give it a go here. I believe that cost and quality don't necessarily go in opposition in a way. And I think the example of what digital health enables and in the spectrum really shows that we can actually, if we have the right view of cost, i.e. not the cost per patient or not the cost per procedure, but if we look at wellness, if we look at the whole citizen wellness instead of sick care, I think that the whole paradigm shifts, and we realize essentially that the quality will be improved with technology and actually will help reduce the cost overall as a system. So I think in short, I didn't see a compromise on cost, as a matter of fact, and I don't see quality and cost being contradictory.
Okay. The next question I got is on digital identity. It's an interesting question. What do the panel believe is the role of digital identity in the ongoing process of digital transformation? And what challenges do you see in the creation of a trusted digital identity that can be used across the healthcare spectrum?
This is Robert from Malafi. We have lots of conversations around digital identities, especially when you're talking, we have a large platform with millions of lives under our umbrella. And so, we have to be thoughtful of how those lives and the information that comes from the different providers in our network matches appropriately. And now you're going to extend this out to more platforms, right? As time moves on, as telehealth expands. The key there is to keep it whole, right? And I like what Majd said earlier, and I'm going to relate this to the cost as well. It's really key to build upon what's in place and improve it instead of starting from scratch, right? And this is where collaboration in a community is key. That's the only way we're going to be successful. Is everybody's doing things in silos. Each of us will be spending money on these initiatives, right? And then, the digital identities will start to become separated as well. And so we need to work together, leverage the technologies that are in place and improve them. So you can lower the costs. You can be cognizant of the person and their identity as well, and ensure we're all speaking the same language. I think that's one of the challenges, that I think is huge that we've come across, is that many of our systems are not speaking the same languages today. So that standardization in the community and broader, within a country or a region is extremely important to make sure that what what my system is talking is the same as, you know, MediClinic or Dana or CCAD. You know, it's extremely important, and we're seeing those challenges today. And I imagine, you know, Wolters, Kluwer, so Alaa, you know, they're probably seeing that hands-on, and people are asking for help in that right now. It's a big issue that we need to tackle, and we need to work with our regulator and as a community to ensure we move forward thoughtfully in that domain.
Absolutely, absolutely. I cannot agree more. So we're seeing that challenge, and with different authorities, even in one country. So every authority has its own standards to meet. The other point is the regulator as well, thinking of, so if you want to think of that coding, so you need to think, how far does the patient data go out of the country or in the country, in the cloud? And because that's highly regulated, and that's part of having a unique patient identity can be a bit challenged by that.
Okay, I just, let's take one other round of questions. We have a few minutes left, and then I'm going to hand it over to Zainab, she can ask some more questions. I think the big challenge that the region specifically is facing is building the infrastructure from the hospital to the home. You know, if you look at other models of care, you know, there's a lot of ways that care can be delivered, and it's not just in the hospital for everything. And I think one of the disadvantages that I find in many, many countries are that they see care as a one-stop care being delivered in the hospital as the one-stop shop for everything, whether it's just a small issue that you might have or a huge big ICU issue. And as we move and the cost of care is increasing, we are expecting a model where hospitals will become the ICU of the future. And a lot of that care will be focused around the community where people live, where they shop, where they work, where they go to school. These are going to be the delivery of care models in the future. So I want to just quickly ask the panel, whoever wants to jump in and ask, what does some of these countries, whether it's UAE or Saudi or others, need to do to help build that infrastructure? We've been hearing about this for a while. You know, Saudi has built a plan of 2030. So what are some of the ideas that the panel has of what we need to be doing and focusing on as voices in the community to build that, to take that forward? So that's going to be my last question, and then I'm going to hand it over to Zainab. So if each of you all can, you know, take a shot at it, that would be great. I'll leave it up to anyone who wants to go ahead and answer.
I start, if you don't mind.
Sure.
I think practicing in the region, first and the foremost that comes to mind would be help from the regulators. So that now that we are sort of breaking the brick and mortar model of hospital care and virtualizing care, I should be able to consult a patient from any premises, not having to have a license for each premises, even though it's in the same ecosystem. So even if I belong to a hospital group, my license is linked to a building and a facility. That silo should be considered to be dismantled completely, given that it was an obstruction in the delivery of care, where in the not so very recent COVID-19 crisis. There were regulatory compensations to say we are not holding you to a licensed premises. You can work across, and that is one of the things that I would like to be stuck even across the pond when we are tiding over the COVID-19. I think that's my only 2 cents. Thanks.
In regards to regulations, I think in Saudi Arabia we do have our telemedicine regulations. So regulation is not a big issue for us, but I think what I see the major focus should be is on designing the workflow with the patient as part of the care team. Currently, I think when a lot of us design our workflows, we kind of tend to forget the patient and forget the input of the workflow. But if we go patient-centric and we design the workflow around the patient, because most of the care doesn't happen in the hospital. Most of the care actually happens at home, at work, in the different places. So if we go and design our workflows with that in mind, with the patient as being the central part of it, then it all actually flows in and the patient becomes actually a part of the care team. and actually probably the most important part of the care team, because they're the ones who are going to be taking out, doing all the care. They're probably going to be self-administrating all that stuff at home, and they're going to be inputting their data. So if we can get that piece out of the clinic and out of the hospital and actually keep the patient at home and only bring them in when needed, that will probably revolutionize the way we deliver care. Right now, most of these devices are integrated. Right now, we're doing our patients with heart failure. We're actually monitoring their weight and their blood pressure when they're sitting in their home. So we decrease the 30-day readmission rate we don't wait for them to come to the hospital with decompensated heart failure. We actually are alerted before, and we actually manage them with something at home so they never come in and stay a few weeks. We cut costs at the same way we improve the patient outcomes. And I think we touched a little bit about patient-reported outcomes, but I see that going in the future as something that we are going to be looking at patient-reported outcomes as a standard of care, which we're not really focusing on right now. So, thank you.
And I think, Tamara, that brings to the whole aspect of the patient taking much more control and accountability of that care model. So unfortunately, I have to leave and jump off because I have another presentation to go to, but I'm going to hand it over to Zainab, who will go through the last few questions with the team. But I want to, on my behalf, I want to thank all the panelists for doing such a wonderful job, and I hope to see you and keep in touch in non-COVID times. Thank you so much. And I'm handing this over to Zainab. Thank you.
Thanks a lot, Reenita. Thanks a lot for moderating it amazingly well. I really appreciate it. And until we see each other, I'd like to say thanks and goodbye. And we'll just continue with the session as we do have a couple of questions from the audience that we have. And I'd appreciate if anyone can take up the question if they feel like answering or they're comfortable with it. One of the questions that was asked is, what about illegality issues, especially with malpractices coverage? We need to implant a lot of changes on the coverage conditions. I'll leave this question for any one of the panelists to answer.
So for somebody to deliver telemedicine, at least in Saudi Arabia, they have to be credentialed and privileged. So that's why we're in Saudi Arabia. It's limited to hospitals that are actually like caregivers that are privileged in their own hospital. So you're actually credentialed and privileged in that hospital. There is the patients, when they sign up for a televisit, they sign a consent, which has the terms of conditions of a televisit. It's not meant to be a full comprehensive because, of course, you cannot do a physical examination. It's totally focused what you can do, but it's a complementary to other types of like a visit or follow-up visit or for the patient to come in afterwards if needed. So it's just meant to be a different form of visit. And it actually helps not delay care because a lot of care delaying care sometimes can result in a more adverse outcome than a patient being able to be timely seen through a televisit or video visits.
Great.
I think just to add to what Tamara said, so the entire medical legal infrastructure in UAE and potentially in the region is an evolving one. In the absence of historical data, so when you come to develop a system or improve the system, you always need to rely on significant historical data, which is readily available with regards to medical claims in the US or UK, but not yet as available here. So I believe what we will do is we will learn as we progress. But definitely I believe adding telemedicine to the standard medical cover for healthcare providers will not be a challenge. And we will just need to observe and modify as we progress. I think what will be more interesting than that is to be able to look at how the regulator and the medical legal framework is going to deal with doctors from outside the UAE, potentially consulting and providing telemedicine and teleradiology services for patients residing in the UAE. So Tamara mentioned that all people who are within this market who are performing are privileged and they're licensed. But I believe a lot of the interesting discussions will be on how to get international clinicians involved in delivering care to our population in the UAE. And this will solve a very big problem. We were talking about what each country needs to do. Each country has different challenges. Here in UAE, our challenge is specifically with regards to capacity, mainly capacity in highly specialized services, like, for example, ophthalmic genetics or metabolic disorders for children, or very rare pediatric subspecialties. So we have an incredible opportunity to be able to tap into these services through our established network of clinical partners and affiliates in UK, Canada, and the US. But we need a very clear regulatory framework to help us navigate through this very important requirement.
And if I may jump in here just to compliment on a very interesting point that Dr. Majd has brought up around the license aspect. I mean, you saw recently, and I mentioned that in my presentation, for instance, in the US, you had to have different licenses between one state to the other. And actually for COVID, that has been lifted. So we could see that essentially doctors could practice from one state to the other. And the question we have is, should every single country open that for all of it? I.e., when you're a doctor, you can practice anywhere in the world for everything, or can we basically be more specific on what licenses? So an example I would like to bring in is, for instance, for radiology reading. So do we need to have, if we kind of use AI and we use the spectrum of variation between of interpretation, can we think of a model whereby doctors are based anywhere in the world, not necessarily having the license in the country, but can still provide medical advice on certain images which are pre-read and made easier. And for that specific specialty, it is possible to kind of go over the rule of licenses. I think it's a very interesting point. I believe digital health will help basically fundamentally reduce that care variation and reduce the risk of malpractice. Now, it doesn't solve it, but I think it will be interesting to look at it from not just, do I have the license or not, but for what do I have the license, and think of some specific specialties that we can that can be more opened up, and where the licenses rule can be eased.
Thanks a lot, Yassine. We'll just take 2 more questions in the essence, and in essence of time, we were supposed to conclude it at 5, but the session is getting very interactive and engaging, and we'll take another 2 questions that we've got from the audience. One of them is, yes, technology is the future and we should rely on it, but how much are we ready for the next pandemic, and how innovative could help us?
Yeah, actually, if you would like, I would like to start answering the question. So I think we're learning a lot through the COVID-19, and we're still learning. We're far away from COVID-19 being done. We're still accumulating data, evidence, and finding the most appropriate way to convey that. And just, echoing again everyone's interest, we will need to enable patients more in making informed decisions into the healthcare cycle. So patients are the most impacted, again, the least participating. They need to participate more because most of the time is spent out of the healthcare setup. So definitely enabling patient through patient empowerment and engagement solutions, providing these solutions with the most updating clinical evidence, so that you reduce the variability in care between and understanding between the physicians, nurses, pharmacists, as well as patients when they are outside of the healthcare setup. So I think we'll continue to evolve, and evidence is going to continue to evolve. This pandemic is not even over, so we're developing many solutions. I think it's also the regulator role to come in and allow many of these solutions to be extended to the patients widely.
I think on that particular point that Alaa was saying, the necessity to make sure that patients' data and patients' information is kept with integrity and safety and security is going to be huge. I don't think there's any vertical, or I don't think there's any service where the importance of controlling and protecting a person's private data is more exposed than within healthcare. I think everybody can see right throughout the world the impact of fake information, and especially during COVID-19. I think that's really, really pushed that idea of how, if I'm going to put my most personal data onto some kind of digital platform, how am I sure that it's going to be safe and secure? And I think that that's still something that a lot of people struggle with, because we can see ourselves the uncertainty and the questions around what is true, what is not true, what is something I can rely on and be truthful, and what is not. That is going to be a huge aspect of future patient involvement and engagement that I still struggle to see. But what I can say is we can learn from other verticals who have implemented very advanced customer engagement solutions, and hopefully that will be rectified for healthcare, because otherwise I think if it's not done properly, it could be disastrous for the confidence that the patients have. Everybody's been talking earlier on about how it's important to have patients at the center. I think it was Tamara spoke about having the patient at the center of this evolution. We also have to have they're going to say their security and their integrity, and that's going to be very important for them as well.
All types of data, to be honest, David, including retinal scans, and more importantly, DNA, genomic sequencing. So UK have just completed their 100,000 genomic study. Abu Dhabi has embraced on a very meaningful 100,000, and they're looking to 1 million, to sequence 1 million genomes. So even going to the level of DNA, your individual DNA, who controls it, who has access to it. I'd love to hear Dr. Shafi speak as well. I really enjoyed his interjection. I'll pass it on to you, sir.
Yeah, I'd love to. Great question. And data is the real key one. I've been trying to figure this one out for a few years. Actually, I don't think it's as bad as we seem it to be, because we haven't approached it in a mature fashion, almost running away from data privacy, all of us in some ways. Look, we all share data already on Facebook, LinkedIn, it's shared, it's at risk, we know that. When it comes to healthcare, suddenly we're scared about the same conversation that we're having, which is crazy. I'd say, look, I ran a conference a while ago and I said to the audience, 1,000 people, what about sharing data? Are you happy? Hands up. All 1,000 put their hands up, so we're happy to share our data. So, okay, next question, what about if you monetize it? And suddenly everyone was a bit, we're not quite sure what to say. Oh, I'm not sure about where I land this one. What we need to do is have an open-ended conversation up front. Challenge it. What is the data that's scaring us? Yeah. And say actually we're far more ready for engagement. We know there's risk involved. We know it can't be completely secure, cybersecurity. However, what the issues that we have with data sharing it, and how can we have different levels of sharing? So one of my friends who's runs a company called humanity.co in the US has challenged this is the 31st human right of data privacy. What they've done is actually, rather than going to a website and saying yes to all data, no to all data, and clicking and moving on, is having levels of 5 different colors. I can share, anonymize, whatever, and actually be in control of what data you're allowed to share, what can be monetized. And that's the more sophisticated argument we need to have. I think we were running scared. We were saying, oh, it's too difficult, and oh, it's going to be so hard. It's not. Let's approach it properly with the patient population, with the regulators, and make some firm decisions. And I think we can actually sort this out fairly quickly, as long as we're bold enough and understand the risks involved and taking a mature approach to this whole problem, if that helps the conversation.
Great.
One thing also about data sharing, so even within our regular data sharing, so a patient, for example, giving a proxy to his father, mother, or a brother to share the data, we actually break it up, like you said, by classes. So so I can share this, but not this. So I think if we're able to segregate the data in this kind of these kind of buckets for, so like highly sensitive things like STDs, or something that you don't want to share, versus it's okay, my immunization record, I don't mind sharing that with anybody, to my genomic profile. I think it all will change, especially when we start seeing the health information exchange across the country, even across different countries. Right now, we are data sharing with Share Care Everywhere, and sharing with different even country with the same patient data, but we're sharing with another institution in a different country. I think at that point, we classify the data and we decide what gets shared and what doesn't get shared. And me as a patient, I get to say yes or no, because in the end, the institution doesn't own the data, the patient owns the data.
think, Tamara, on that one point, actually, I'm interested. Dr. Ahmed is also a TEDx speaker. There's a very good TED speech from a number of years ago from a guy called Barry Schwartz, I think it is, on the paradox of choice. And it's absolutely fascinating. I'd recommend people view it because it was well before, apps and smartphones and so on. But he makes a great point. And to your point about giving people choice is a paradox. The more choice you give people, the more complexity and stressor that can actually result in people. So I think, again, this is where the patient voice will be absolutely critical. Is choice to a patient of whether they provide certain amounts of information but not others? Does that complexity, especially in healthcare where there is an unavoidable amount of complexity, does that result in stress and probably reluctance from patients as well?
Well, and I think there's different ways to approach that too. I mean, from a health information perspective, the things we're looking at is to empower the patients, as we move forward with our journey, to be able to tell a patient that provider X at facility Z access their information. Now, I think that starts taking, the information that we have readily available and tells the patient exactly what's happening to their data. To me, that's a key piece in the puzzle, right? So not only give them the choice, but give them actionable data. I mean, that's what we're all talking about in order to help improve our responses, right, to COVID or anything else that may come across from a healthcare situation. So, again, it's actionable data in the patient's hands. That's just beyond the clinical data that we're talking about, but also what's happening with their data. Those are the type of things from a health information exchange we're absolutely looking at and our roadmaps to be able to implement and provide to the people of Abu Dhabi.
Can I quickly add to that as well? I think the stress that we just spoke about, the paradox of choice, is a very interesting concept. And I think you can reduce it, mitigate it to some extent by saying to the patients, if at any given point you decide to withdraw certain aspects of your data privacy or consent, beg your pardon, you are able to do that. So you're not signing off your life now. It's like a cooling off period that a dealership gives you. If you don't like it, you return it back in 14 or 30 days. So I think that's very important as a level of security to the patients to say, the decision I've made today is to the best of my knowledge today, but I can review it with my friends and family and get back and maybe withdraw a couple of them if need be.
Apologize. It's a very interesting discussion. However, I have a next call, so if you don't mind, I'll just check out myself. Thank you.
Sure. I think this is the last question that we'll take before we close the session. And the one that we have is from Mr. John Langford, who's joined us from States. And his question is like, if we listen, the patient will drive change. Great conversations. The patients are ready. The question is, are we?
Well, I think we're more ready than we were before. That's what I like to say. Put out that question slightly as a clinician. But I think you're right. I think, as I said before the outset of this conversation, the patients are really ready. We've been really paternalistic about how we looked after them and understood their requirements and their decision making. And I think we're on a much more equal footing now. Realizing actually is about partnerships, it is about collaboration, it's about moving that needle forward together. So I'm hoping that we are more ready now to embrace that kind of relationship that will allow us to, I guess, change healthcare and reset that new normal. So I'm, I guess, eternally optimistic that I think we can make some changes that are more effective going forward.
And if I may, actually, I think technologically we're ready. I think adoption-wise, and there are different stakeholders here, not everybody feels ready. They think they're ready, but I just would like to remind the people that there are still hospitals here in the region that are not digitized, let alone talking about digitalization, and patient records are still in paper folders put here and there. So, so yes, we're somehow ready, but I think there's still a lot of work that needs to happen by providers, by regulators to adopt the technology and actually engage in the journey. The journey is long. It's not something that will be done overnight. We need to acknowledge that and just be open to the ride in a way.
I agree, Yassine. While I'm extremely proud of what we've done here in Abu Dhabi, I still think there's a lot of data that is not available to clinicians in order to make the right decisions. You know, we've started that journey, but I've heard, you know, dark data, that's EHR data that is not, you know, necessarily easily pulled out and then shared easily, you know, with the community, right? So we have a long journey to go. So I would say we've learned a lot and from this COVID crisis that still continues. You know, Winston Churchill quote, "Never waste a good crisis." We need to continue moving forward with that and unlock, you know, our potential. You know, technology's there, right? But there's a lot of things, you know, from a regulator standpoint, policy standpoint, that we have to be thoughtful of. And you know, I saw someone in the chat put in there, you know, don't provide a lot of choices. We have to provide patients and people, I like to use people, choices, but don't overburden them with those. Cause, you know, myself included, if I have 8 choices in front of me, you know, I'm like, A, B, C, D, I'm not sure. You know, you give me A, B, or C, it's a lot easier to move forward. And I think we have to simplify some of those things to move forward responsibly and quickly.
Thanks, Robert. I think I agree with you. Other than data, I think we still need to work a little bit on the device integration and the patients, not only the wearables, but I think the future, the care at home in the future is going to see a lot of changes from different types of sensors, the augment, like right now when I look at our telemedicine carts and I see what we're doing in like our remote area clinics and being able for a doctor in Dhahran to be able to hear a patient, his heartbeat and be able to check his ears and check his skin and all that stuff with these diagnostics remotely. I think we're going to see a lot happen at home in terms of sensors and wearables and device integration. So I guess more to come. This is very rapidly changing. So the years ahead will show us.
Agreed.
So great. I'd like to wrap the session. It's been an absolutely interactive and an engaging session, and I'd like to thank all the speakers and the panelists for their invaluable contribution by way of sharing their expertise and comments. We've taken a recording of the session and we'd be sharing it with all the participants, including the speaker and the panelist panel. And I'd like to thank each one of you for your active participation. We do deeply appreciate your participation. And I'd also like to extend a word of appreciation and thanks to our partners and sponsors. I repeat again, that's Wolters and Kluwer, our digital partner, GE, Avaya, CGC, Malafi, UEMedical, and HealthPlus. And it's a great conversation that we've built up, and we hope to continue this back again in our second edition. Until then, we'd also appreciate all of you to kindly share your feedback of your experience of being part of the session. That would help us improve as to how we serve you better the next time. So thank you very much for all your time. Have a great evening forward, and we hope to see each other back again, hopefully soon.
Thank you.
Thank you. It was lovely meeting you all.
Thanks so much, everyone.
Thank you.
Thanks, Zainab.